Okay, so welcome to part 5 of this video on epilepsy and the gabapentinoids. So in the previous video what we had begun doing was the anatomy of the biceps brachii. So the biceps brachii is the muscle we're going to use as our example of what happens in an epileptic seizure, which is convulsions of the muscle. Okay, so biceps basically is a muscle with two heads, which is why it's called biceps. But it starts off lower down as just a single muscle basically, and we can draw it like this. And it has the biceps tendon, which attaches into the radial tubercle down here. So that's the biceps tendon. Biceps tendon. Okay, and it starts off as just one muscle basically here. And it is one muscle. Biceps is one muscle. It's just it's got two heads. And then later on, it splits basically, and it's into its two heads. So here's one of the heads of biceps, and here's another head of biceps here. Okay, and they basically attach to different bony structures. So here's the long head of biceps. So the one that's on the lateral side, i.e. facing out from the center of the body, is the long head of biceps. This one here. This is the long head of biceps. Long head of biceps, and the medial one is the short head of biceps. So this is the short head of biceps. Short head of biceps. Okay, so the long head of biceps has a tendon that leaves it as well. So this is the tendon, and it runs through this intertubercular groove. That's the name of that, not intertubercular notch, which runs between the greater tuberosity of the humerus and the lesser tuberosity of the humerus. Greater tuberosity and the lesser tuberosity here, and that then lesser tuberosity that then runs over the humerus and attaches to a supraglenoid tubercle on the scapula. So we're going to have to put the scapula in here if we want to see where this goes. So here's the acromion of the scapula, which goes down like that. Then you have the coracoid process, which comes out like this of the scapula. And then the rest of the scapula is sort of like that sort of a structure like there. Okay, so it kind of goes like that. Okay, there's a surface which articulates with the humerus here, but above that is something called the supraglenoid tubercle. So this is the supraglenoid tubercle, and that is where the tendon of the long head of biceps is going to attach in there. Okay. Right, and whereas the tendon of the short head of biceps is going to attach to the coracoid process here. Okay, so this is the coracoid process of the scapula. So both of the tendons of the scapula, both of the tendons of the biceps muscle superiorly attach to the scapula, different structures of the scapula, and the tendon below attaches to the radius. Okay, so underneath this muscle is where the brachial artery runs. So here comes the brachial artery down like this, and it runs just underneath the biceps, and basically alongside it runs the musculocutaneous nerve, which has come from the lateral cord. So division of the lateral cord is the musculocutaneous nerve, and basically it's the musculocutaneous nerve that innervates the biceps. So all of these alpha motor neurons, which came out of the spinal cord at spinal roots, oh sorry, you can't see this, at spinal roots C5, C6 and C7, they have gone through and gone into the musculocutaneous nerve from the lateral cord, and they are now going to terminate by innervating biceps. Okay, and if you remember right back to the beginning, we had this epileptogenic focus driving the primary motor cortex to fire spontaneously, and that is going to drive these alpha motor neurons to fire spontaneously. So we're going to get a huge amount of stimulation onto this biceps muscle, and that's going to cause our convulsions. So now we'll just do a quick recap of how you get how you stimulate muscle and how that causes contractions, and then we'll discuss the gabapentinoids and their use in treating epilepsy. Okay, so these axons, what we now want to do is, if we put the anatomy aside, what we now want to do is we want to study how the axons, so we've got this axon that has come all the way down the musculocutaneous nerve and is now going to synapse onto a piece of muscle. Okay, so this is our blue axon, our alpha motor neuron that has finally made it here. Okay, now muscle has a interesting structure. So if we go back to the macroscopic structure here, if we were to take a cross section, if we were to cut across this biceps like so, if we were to take a plane like that and look at what the structure of the muscle is in that plane, what we would find is something that looks like here. So this is the outline of our muscle, and basically you find that it is segregated up into loads of little muscle fibers, basically. Okay, so these aren't the muscle fibers; these are the fascicles of muscle fibers. So a large way in which it's divided up is that it's divided up into fascicles initially. Okay, so the muscle fiber, the whole muscle is here, and inside the muscle you have loads and loads of fascicles. And basically, if you take apart a fascicle, what happens is that you find inside the fascicle loads of little muscle fibers, and these are called myofibers. And basically, if you then look at what a myofiber is, then the myofiber itself is made up of loads of even smaller things. So this thing that I've taken out, this myofiber, is now this entire thing. The myofiber is made up of loads of even smaller structures called myofibrils, and the myofibrils are the analogy of a cell, basically. They are absolutely massive, though. They are much bigger than normal cells, and what they really represent is loads of cells that have fused together to make something bigger, a bigger structure than a normal cell. So these are myofibrils. And myofibrils are the contracting units of muscle. Okay, so when we say an axon is going to synapse onto a muscle, what it's actually going to synapse onto is a myofibril. So we've got a myofibril here. And basically what happens is that when the action potential comes along here, we know that that causes a depolarization of this presynaptic membrane of this axon terminal. And when the axon terminal depolarizes, we know that that allows calcium to enter the neuron. Okay? Calcium then causes the exocytosis of neurotransmitters, so the synaptic vesicles are then emptied into the synaptic cleft. And in the case of a neuromuscular junction, as this is called, the neurotransmitter that is used, neuromuscular junction. In the case of a neuromuscular junction, the neurotransmitter that is used, this neurotransmitter which is going to be released, is acetylcholine. Okay, so acetylcholine. And the structure of acetylcholine is quite interesting. So firstly, let's look at the structure of choline. So the structure of choline is that you have two carbon molecules with a hydroxyl group on the end and hydrogens everywhere else. Apart from at this end, what you have is you have a nitrogen which is bonded to three methyl groups, like so. And this basically is the structure of choline. Of course, the nitrogen will end up having a positive charge because it shouldn't have 4 bonds. So this is the structure of choline. To turn it into acetylcholine, what you do is you make an ester link with this hydroxyl group. So basically what you do is you take acetic acid, which is this structure here. So this is acetic acid. And basically you make an ester link between these two. So you remove the hydroxyl group off the choline, you remove the hydrogen off that hydroxyl group of the carboxylic acid group, and then you bind this carbon to the remaining oxygen on the acetyl group, and you get an ester link. So this is the new ester link. The hydrogen and the hydroxyl group then combine to make water. So that's the structure of acetylcholine, basically. So acetylcholine is released into the synaptic cleft. It diffuses across the synaptic cleft to the postsynaptic membrane, which has in the membrane, it has acetylcholine receptors. Specifically, it has nicotinic acetylcholine receptors. So that little receptor I've drawn there, that thing which I'll highlight in green, is a nicotinic acetylcholine receptor. So this is a nicotinic acetylcholine receptor. Okay, so acetylcholine is going to bind to that nicotinic acetylcholine receptor, and the nicotinic acetylcholine receptor is going to open when the acetylcholine binds. When it opens, it will allow sodium into the cell, which will cause a depolarization of the myofibril membrane. When you get a depolarization, that will then lead to an action potential. So once you depolarize the cell to negative 40 millivolts, the voltage-gated sodium channels will open. So let's draw in a more voltage-gated sodium channel here. So the voltage-gated sodium channel channels will open. That will move the electrical potential difference across the cell towards the equilibrium potential for sodium, which is much more positive, so more sodium will move in, and that will depolarize the membrane overall to plus 40 millivolts. And basically, the sodium channels will close after a certain amount of time, and when they start to close, that's the end of the depolarizing phase, and they close at about once they close, the depolarization they have achieved so far is at minus 40 millivolts. I want to stress that they do not close because the voltage has got to minus 40 millivolts. They close, and at the time that they close, the membrane has depolarized to about plus 40 millivolts. And then the next part of the action potential is that when you depolarize the membrane initially to minus 40 millivolts, the voltage-gated potassium channels also opened. So let's draw these voltage-gated potassium channels in here. They also opened, and basically they all were also activated by the depolarization. However, they take much longer to open, and they don't open until the amount of time they take to open is such that they don't actually start opening really until the sodium channels have started closing. So they start opening just as the sodium channels are closing, and they allow potassium to leave the cell, which makes the electrical potential difference across the cell membrane go lower again. It repolarizes the membrane. Okay, and then what happens is that in the phase when when sodium has moved into the cell and caused depolarization here to plus 40 millivolts, the sodium starts diffusing to neighboring bits of the membrane, and that causes the neighboring bits of the membrane to depolarize, maybe to beyond minus 40 millivolts. And then that neighboring portion of the membrane will fire an action potential, and in that way the action potential can propagate along the membrane. Okay, so the way in which this action potential firing across the cell membrane of these myofibrils is coupled to the actual contraction of the myofibrils is that the action potential propagates along, and then there are structures in the myofibril called T-tubules, basically. So what happens, which are basically just these indentations of the cell membrane inwards. So there are invaginations of the cell membrane of the myofibril inwards. So what happens is that the action potential propagates inwards, and basically in these T-tubules you have certain types of L-type voltage-gated calcium channels. So down here there is going to be an L-type voltage-gated calcium channel, also called a dihydropyridine receptor. So this is either you can call it a dihydropyridine receptor, or you can call it an L-type voltage-gated calcium channel, or you can call it a calcium V1 point whatever. So it's calcium V1 basically. Okay, and when the action potential makes its way down here, obviously what's going to happen is that the voltage-gated sodium channels are going to open, and that's going to depolarize this membrane to maybe plus 40 millivolts. So these voltage-gated calcium channels are therefore going to be activated by this depolarization and are going to open and allow calcium to enter the cell. However, that's not the important thing. The important thing is that these dihydropyridine receptors are in some way linked to another receptor that is in the sarcoplasmic reticulum. So basically, sitting around these T-tubules, you also have the sarcoplasmic reticulum. So this is the sarcoplasmic reticulum, which is just the endoplasmic reticulum. It's the same thing as the endoplasmic reticulum, but if you're in if you're in a myofibril, it's instead called the sarcoplasmic reticulum rather than the endoplasmic reticulum. Now, in this myofibril and in all cells in the body, calcium in the cytoplasm is kept very, very, very low. So instead it's all stored in the sarcoplasmic reticulum and extracellularly. So you might think, well, okay, this voltage-gated calcium channel has opened, so it's let some calcium in, but it lets hardly any calcium in. That is not the signal for the muscle to contract. And the thing that makes the muscle contract is that calcium goes up, but it is not that calcium goes up because you've opened this. Instead, this dihydropyridine receptor is in some way linked, physically it's believed, because they're very close to one another. it's in some way linked to another calcium channel that is within the sarcoplasmic reticulum, and this calcium channel is called the ryanodine receptor 1. Ryanodine receptor 1, sometimes abbreviated to RYR1, like that. So that's the ryanodine receptor 1. Over there, and basically when this dihydropyridine receptor is activated by the depolarization of the membrane in the T-tubule, it causes this ryanodine receptor 1 to be activated in the sarcoplasmic reticulum. So the ryanodine receptor 1 in the sarcoplasmic reticulum opens, and this allows calcium to leave the sarcoplasmic reticulum and enter the cytoplasm. So calcium rushes out and goes into the cytoplasm, so you get a much higher concentration of calcium in the cytoplasm. So that is how you get a large increase in the calcium concentration in the cytoplasm of these myofibrils. It is not because of the opening of the dihydropyridine receptor. The dihydropyridine receptor, or the L-type voltage-gated calcium channel, its role is really to cause the ryanodine receptor 1 to open. Okay, so now what we need to explore is how this calcium going up causes the myofibril to contract. Okay, so now what we need to discuss is the more microscopic structures inside these myofibrils. So, if we draw a myofibril here, then basically what it's made up of is loads and loads. It contains absolutely loads of protein, and the proteins are what actually contract inside these myofibrils. So basically, what you find is that there are two main pieces of protein in the myofibril which are responsible for contracting, and you basically have discs in the myofibril which attach one of these proteins. So you have discs like this which attach a protein called actin. So these discs attach actin, and they are called Z discs basically. So Z discs are their name. So the Z discs have this protein actin sort of radiating out like this. So the Z disc is in the same plane as the myofibril. So the myofibril goes in this direction, and it's a circular shape. Basically, the Z discs lie in the same plane as the circular cross-section of the myofibril. Okay, so they lie in the plane perpendicular to the direction in which the myofibril is stretching and the direction in which the myofibril is going to contract. Now you have another Z disc over here which also has more actin attached to it. And I should say that obviously this Z disc over here will also have actin going the opposite way as well. Okay, and basically then what you have is a different protein which is suspended in the middle basically like this. And this protein is myosin. So the green protein is myosin, and it's suspended. It connects basically the actin filaments. So these long chains are called actin filaments, and the reason is that they're not just made up of one actin molecule; they're made up of loads of actin molecules. So basically, an actin molecule you can draw as a circular protein, and basically to turn it into an actin filament, what you do is you connect loads and loads of actin molecules together. So this is the structure of an actin filament. Similarly, myosin's shape is more like this basically, and what you do to create a myosin filament, so this is a myosin filament, what you do is connect loads of them together. So you put another one maybe here, another one maybe here, another one maybe here, and you get this sort of structure overall that has loads of these little globular bits sticking out. So you have this fibrous bit of myosin and this globular head. So this is called the myosin head, and this is the bit that's going to interact with the actin. So basically, overall, the big picture of what's going to happen is that when calcium goes up, what's going to happen is that the actin filaments are going to pull these Z discs closer to one another to cause a contraction, and that's how contraction happens. Okay, so the mechanism by which this occurs is that usually, well, actually, Firstly, we have to say what usually stops this from happening, because in fact what happens is that there is usually something stopping the myosin filaments from pulling the actin Z discs towards one another and causing a contraction. And the rise in calcium within the cytoplasm in fact inhibits that inhibition, and that's how it activates the overall contraction process. So rather than activating the contraction process, you're instead inhibiting the inhibition of the contraction process. And we'll continue this discussion in the next video.